Hello again, everybody. It's me, Jessica Shurer, the Director of Clinical Affairs and Advocacy at CurePSP. You heard from me on Tuesday. It's a pleasure to be with you again today in this virtual space. And today for our Q&A panel, it is an honor to have with me Dr. Jennifer Brummet, our Associate Director of Scientific Affairs and Partnerships here at CurePSP, and Rachel Dorsey, who is an occupational therapist at University of Florida, both of whom you just heard from in the presentations from when we were in Orlando last month. So they are here to answer your questions, which you have submitted when you registered to attend this. We've also received a few questions in the Q&A live here today. If you still have a question that you want to ask one of us, please go ahead and submit it in the Q&A tab on this platform that you're viewing this in. Two notes before we get started. First, unfortunately, Dr. Zezowicz was not able to be a part of this panel today. She wanted to, but she's in clinic, so she apologizes. But if you have any questions about her talk, which was on the topic of multiple system atrophy, please go ahead and write it in the Q&A, or you can email us after, and we will pass them along to her and follow up with you by email. Also, we shared this on Tuesday, but we always have to share a reminder that information that is shared in the presentations and on this panel is just meant for educational purposes and not meant to be medical advice. So welcome, Rachel and Jennifer. Thank you for being back with us. The first question that we had received in registration for Dr. Brummet, I'll ask this to you first. And this is a loaded one, but it's a really good one. What are the promising or exciting types of research taking place right now for these diseases?
Yeah, that is a loaded question, but it's an exciting question that we love to think about all the progress is being made. So I'll do what I can to answer it. There's so much out there. I certainly won't be able to cover it all here today, but I'll try to highlight a few things that I find exciting. To me, the main exciting thing is really just how much research has accelerated in terms of interest in what's being done and the true breadth of research that's being done across the research spectrum. There's a wide range of basic research, translational research, and clinical research that's being done in a variety of different topics. And that's what's really needed. A broad range of research coming at these questions from different angles is absolutely essential. And it's really exciting to see what's happening. A few things in particular that I'll highlight. First, as I might have mentioned in the talk you just watched, and I've mentioned on other webinars if you've joined me, I really find this recent CBD biomarker study to be a great finding. And that's because improved diagnosis is truly something necessary in this field. And a research team found last year a certain type of the tau protein that was correlated to having CBD. And that's something that's still in the laboratory and not necessarily something that's made it into the clinical setting yet, but it's the type of research that really just needs to be done to help improve pretty much every aspect. It will improve diagnosis if it moves forward. It will improve research. It will improve clinical trials. It's just the type of finding that is really needed to accelerate research in these areas. And related, we've also been really excited by recent developments in the Parkinson's disease field. They've really accelerated the number of diagnostics they've been able to bring to a clinical setting. And while that's not necessarily directly applicable here, the one benefit it has for us is that, as many of you know, there's a lot of misdiagnosis that occurs. And so as these other diagnostics start to take shape, it will really help clinicians really hone in on what's happening, which will really benefit everyone. And much like the CBD biomarker, these Parkinson's diagnostics are really going to help improve clinical trials and diagnosis. And there's still more work to be done. I don't want to imply otherwise, but the momentum that we've seen the last year has been really reinvigorating for the field. And I have confidence that it will continue to move forward. And I'll stop there for now.
No, yeah, that's such a good point. I mean, that's particularly exciting progress that we're seeing. I think there's going to be a lot more to come out of that, and we'll turn to you to keep us updated.
Absolutely.
Question for Rachel then. Also a big question, but also equally important. And I know that a big part of this is it depends, but do you have recommendations for preventing falls forwards and backwards in the home?
Yeah, so there be a little bit general, but there's some basics. I went over some of them in my talk, but definitely keeping walkways clear. You want to make sure that you're utilizing the proper assistive device recommended by your therapist. Minimizing distractions or doing more than one thing at a time while moving around or walking is a good way to prevent a fall. A good functional exercise to practice is just literally practicing sitting and standing, doing this without your arms if possible, or using your arms to push up and down. It's a good way to strengthen, and it's a good way to work on balance in a functional way. If it's something you need help with, you can do this with a caregiver by you so that you can practice that, and that's a really good way. Walking for exercise, one of the things we know is that if you want to get better at something, you have to practice that task. So making sure that you're practicing your walking and you're getting up and moving regularly. And then getting regular aerobic exercise to help maintain your endurance, because you want good energy levels to be able to do the things that you want to do. As well as also resting proactively. So you're going to exercise to be able to make sure that you have the endurance to do tasks, but then when you're going to rest before you get to that point of fatigue, because fatigue is one of the risk factors for falls. I do recommend working with a physical therapist on individualized physical exercise, mobility training, and balance exercises so that they can be specific for you. And an occupational therapist can help you with safety doing your regular daily activities.
Great tips. Thank you so much. And I'll add to that too, if I may, that it's not only is it very individual person to person, but there's specific considerations for the diagnosis itself too, right? So like in PSP, for example, and CBD to some extent, a lot of the falls can happen as a result of sort of impulsivity sometimes, like somebody sort of just like shoots up from a chair really quickly without planning to get up slower, and that can lead to a fall. And an MSA, a lot of people will fall, we'll see, because of the drop in blood pressure, the orthostatic hypotension when they go to stand up. So there's the disease specific considerations too that I am sure you and your OT and PT colleagues work around when you come up with a plan of care.
And I think this question was asked at registration too. So I had gone over some of those things in my talk. So hopefully those were answered as well.
Yeah. Okay. Question back to Dr. Brummet. Are there prospects for PSP treatments being developed by current research?
Another great question. And yes, there are certainly prospects out there. One of our partners at the Rainwater Charitable Foundation actually just put together a really great paper that is open access and available. Actually, it's on the therapeutic landscape for tauopathies, which are therapies targeting the tau protein that's implicated in PSP and CBD. And they put together a really comprehensive overview of different therapeutics that are in the research pipeline at the moment. So there are quite a few that are in the preclinical stage, and that really still means that they're in the laboratory. They're not making their way to patients yet. They're in the promising preclinical stage of development. But thankfully, there are some that have moved into the more clinical stage that are in stage 1, 2, and 3 trials, moving along the research pipeline, frustratingly slowly at time, but promising prospects nonetheless. One that I'll highlight that has been getting some attention lately is Amylyx did release an announcement about an upcoming phase 3 trial that they plan to commence by the end of the year for PSP in particular. That's important to note. We don't have a lot of details yet because it hasn't been fully registered on clinicaltrials.gov yet, but we are excited for that prospect as well. And that's more details soon. We're excited to share that. But more broadly, there are several ongoing, research and development prospects out there targeting different components of it. And the focus is always on therapeutics, rightfully so. We all want better treatments and a cure. But I also want to note, too, that in terms of, promising prospects and research out there, there are also trials focusing more on like the technology development and things that can help improve quality of life. So there's really a lot of different prospects out there, and CurePSP does our best to help get the word out about those to our community.
Absolutely. Okay. I'm going to ask a question to myself. I don't know how to do this unless one of you wants to answer, but somebody asked in the chat, in his presentation from day one of the family conference, they didn't say that, but this is when he talked, Dr. McFarland mentioned that there was a PSP type that had a longer duration or slower progression, but he didn't mention which one, and is there a specific name? So my understanding is that looking at the progression of different subtypes of PSP, and there are many, but the most common subtype is called PSP Richardson's syndrome. The second most common is PSP Parkinsonism. And then the remaining, so those two make up about 75% of cases of PSP, and the remaining 25% is lots of other subtypes that are all kind of symptom specific or based on their clinical presentation. But anyway, to this question, it seems to be the PSP Richardson's type that progresses a little bit faster. Even at sort of baseline, coming in on first screening at the same disease severity as someone with PSP Parkinsonism, the PSP Parkinsonism progresses a lot slower compared to Richardson's syndrome. So I hope that answers that question. Okay, question for Rachel from the chat. I am asking for my mom who has CBD and lives out of the country. Are you aware of any option? And I reworded this just a little bit to make it a little bit broader for our audience, but are you aware of any options for physical and occupational therapy services offered online?
So telehealth has been a lot more popular, particularly after COVID. But generally, when it comes to the US telehealth limitations, you have to be in the state that the provider is in or is actively in physically in order to get services from there. So I don't believe there's anywhere in the US, but there is therapy across the world. So I would look in your local resources, and I would just Google telehealth therapies in whatever country or state you might be in.
And it also, for that person, if you want to write to us, if we know, and maybe tell us what country your mom lives in, if we know of a resource in that country, or maybe we could help do some research, we are happy to share that with you. And another thought I have too is that on CurePSP's YouTube channel, we have we used to have a sort of a webinar, a monthly-ish webinar series called Wellness Wednesdays, where we had all different rehab therapists and exercise professionals come and do a recorded seated exercise. And then we also had something like that for our wellness workshop, which is our virtual conference last spring. And that's also on our YouTube. So while they're not tailored therapies, there are some options for seated exercise that you can look at virtually from anywhere there too. Okay, Dr. Brummet, back to you. Can you provide information on clinical trials and how people can learn about participating?
Yeah, this is a great question that comes up a lot. So I'll do what I can to answer it. My first recommendation is always that if you haven't done so already, I really suggest having a conversation with your clinical care team about your interest in participating in a trial. Many physicians do their best to be proactive with this, but I think a conversation is always really helpful just to make it clear, and they can, help advise you along the way in terms of what trials may or may not be a fit for you in particular. But more broadly, clinical trials, at least in the United States, all have to be registered on a website that is clinicaltrials.gov. I'm sure many on the line are familiar with this website already. It is not user-friendly, though. I will be frank. It is a tough website to navigate in many ways, although you can search specific to a certain diagnosis. So that is a helpful feature. In terms of more user-friendly interfaces to find trials, I highly recommend Michael J. Fox's Trial Finder. It's really, really user-friendly. They let you search specifically by diagnosis, including PSP, CBD, or MSA, and you can enter in information along the way, such as how far you're willing to travel, time since diagnosis, if you've had certain treatments along the way, and things like that that might impact your eligibility for certain trials. It's a really great resource that is much more user-friendly and easy to navigate than clinicaltrials.gov. And most clinicaltrials.gov and the Trial Finder, which pulls from that information, will have often websites for trials or contact information. So if you see one that looks of interest, I recommend both raising it to your clinical care team, but you can also reach out directly to the contacts listed on those sites. They're there for a reason. They want to connect with potentially interested participants. You should make sure you get the information you need to decide if it's the right trial for you. It's a two-way decision, and both your clinician and the trial coordinators are there to help you in this decision. But those are my best tips. It's a difficult system to navigate at times, though. So I just think being in touch with people is the best way to really navigate it. And again, CurePSP, we do our best to monitor developments and promote trials that are looking for participants. It's a win-win situation. Often trials have a lot of difficulty contacting participants at the right time in order to complete their recruitment. And then on the flip side, our community always wants information on how to participate, and we really do our best to connect those dots along the way, and we'll continue to do so as hopefully new developments emerge.
Thank you. Okay. Another question for Rachel. My husband, and this also was from registration, my husband enjoys using pastels to do artwork. What can be used to help him do this more easily? I love that question.
So this was a little bit of a challenge, not knowing diagnosis or specific concerns, but I came up with just some kind of general recommendations. So first thing is just simply sitting in a supportive chair, and then making sure you have a good support under your paper or canvas. So sitting at a table or making sure the easel is very strong. Assuring there is good lighting. And then coming back to what I was talking about vision before, is using single distance lenses. So like readers, so that you can very clearly see what you're doing. You wear progressives, then just having readers to be able to see clearly what you're doing. Sometimes the use of a forearm bridge, this helps hold your arm up over artwork to avoid smudging, but still allows some stabilizing with it. There are holders for pastels to improve grip and control. I recommend picking just the best time of day that you have good energy and focus to be able to do the activity, particularly maybe after exercise, so that you're a little more alert and able to focus on the task. And then just kind of generally what I recommend, particularly if doing pastels was something that was done before the diagnosis, and maybe it's something that the person was very skilled at, is I recommend kind of approaching it as a creative outlet versus focusing on the outcomes of the work. It can be a little bit hard to compare to what it was before, but one of the things we know is that, artistry and creative expression changes throughout life and how as life changes. So kind of being free to use it as an expression in a way to kind of discover what might be coming about that's different, versus trying to recreate what might have been done before the diagnosis. But it can be a really good way to kind of deal with that and have a good outlet and a good productive use of time and feel good about your time. So.
Thank you. I think I love that question because it really shows like the true breadth of what OTs can do when it comes to supporting independence and everyday quality of life. It's not just about getting dressed or transfers or bed mobility or feeding or driving. I mean, you do all of these things, but it's also like it's enjoyable activities too, not just necessary ones. Things that you would like to still do that you used to do that's harder to do now, and making adaptations so you can continue to find joy and engagement.
Yeah, totally.
Dr. Brummet, a question just came through that I'm hoping you can answer. Can you talk about CRISPR and what that is and what research might be being done around that right now and with these diseases?
Yeah, so CRISPR at a high level is a genetic editing technology, essentially, where scientists can find a way to target certain genes or parts of genes and either usually remove them in some way and try to impact the outcome of it. In general, for these diagnoses, CRISPR is something that's still more in the exciting potential range and not necessarily something that's in the clinical promising range. And that's in large part because a lot of PSP and CVD cases in particular don't have a strong genetic tie. The genetic understanding for a lot of these diagnoses is still unclear for most people. That, there's a lot of researchers continuing to look into this, but without a clear gene to target, CRISPR's usefulness is unfortunately fairly limited in those cases. So, but it's an exciting technology that's out there. There's definitely a lot of work being done on it in the broader scheme, but unfortunately, in this scenario, it's something that is not being directly looked at the moment.
Okay. All righty. Thank you. I'm sorry. I'm like clicking around here because I'm looking at the questions and then coming back to you. This wasn't a question per se, but I think that we could address it. Somebody shared, if my husband sees a movement disorder specialist, oh no, it is a question. Will his current neurologist likely not want to see him? And, not knowing all of the details of that, I would say that I think a really good healthcare clinician is not going to ever stop you from seeing somebody else, right? I would hope that there's not that kind of competition. In my years at a movement disorder specialty clinic, we would usually recommend that if someone lived farther away, it was helpful to have a local neurologist, even if it was a general neurologist, to have local care and then come to our subspecialty clinic, maybe just 2 times a year or something. And then we would send our notes to their local neurologist because it's just so much easier to have local care than driving 2, 3, 4 hours for specialty care. So ideal world, you could have 2 and they should be coordinating with one another. Now, that being said, sometimes things can get a little bit tricky if you have 2 different providers giving you very different advice or, recommendations for your treatment. So it's just something to keep in mind. And if that arises, just talking to them about that, like, oh, it's interesting. You're recommending that because that's pretty different from what this person over here recommended. And, why is that? And can you all come up with a consensus? So that's just one consideration in that. But I think at the end of the day, what's most important is to have a team of people who you have chemistry with, who you trust to turn to, who understand you and your family member and your lived experience and your diagnosis, because you're going to be working with them for a long time since these are chronic diseases. And I don't know, Rachel, as a clinician, you want to add anything to that?
No, here working at a movement disorder specialty clinic that people travel from as well. We have a mix. Some people only have their movement disorder specialist because they found that they understand the disease process the most, and they've just preferred to stick with that. But then we have other people who have, just like you said, that they come once or twice a year here, and then they see their local neurologist in between. And it really is just kind of what works the best for people.
Rachel, this didn't come through the chat, and I apologize if it's redundant to something you might have covered in your presentation. It's been a month since I got to watch it, but can you speak to recommendations you might have for working with care partners or maybe even professional caregivers directly, like as part of caregiver training? And I'm asking that because a lot of times in our clinic or in the rehab side of things, we would have family just drop off the person with the diagnosis for therapy and then come pick them up an hour later when they were done, which is, understandable. But at the same time, I know it can make it a little bit more difficult for carryover into the home. So can you talk about how you work with, both people?
Yeah, and I definitely understand how sometimes therapy sessions are utilized as a respite for caregivers. And I would say that as a rule, we don't say that caregivers have to be here for every session. I will say if there's more cognitive concerns, then at least touching base each session is really good. But, sometimes we decide hey, next session, you're going to come in and we're going to do fall recovery. And we're going to practice how to help that person get up and down from the floor. Or we really need to go over this technique or these cues, those particular cues to be able to get on and off the toilet and manage your clothing appropriately. Or sometimes coming in and teaching stretching techniques or how to help make sure that this exercise program is followed through with to help when sometimes there is either cognitive or movement planning issues. So it can definitely be helpful for caregivers to come and participate in some aspects of the therapy and just communicate with your local therapist about that. Sometimes I even recommend coming in with kind of a list of what things you do want covered. Is like, hey, you know what, this is really a problem at home. Can you go over this? And then maybe we can go over how to do this together so that it's a little bit easier. And then when people do have hired caregivers, I really very often do recommend them coming in to learn techniques for transfers or exercises, especially if you're paying for services, then this is a great time to be able to have better carryover for exercises. So to have them come in and learn what we're doing in therapy so it can be carried over at home. And then in that same sense, I know it's not always financially feasible or able, but even just in your own setting of having caregivers, new hired caregivers on, I often recommend if you can have them just more hanging out with you and the patient for a couple shifts so that they can just see how you're communicating and reinforcing that and what their regular routines are, that can be helpful too. But yes, we can be a really good resource for how to make life easier for you so that you're not reinventing the wheel. So, yeah.
Rachel, I hope you don't mind that I just keep asking you questions because they're occurring to me as you're sharing. How often do you feel like somebody should participate in OT or other rehab therapies? And the second part of that is when should they do it? Should you do it preemptively? Or should you do it, when issues arise? And it's hard because it's hard to predict everything that can come up, but it's also you don't want to play whack-a-mole every time a new symptom pops up.
Yeah, exactly. We definitely believe in the preventative aspect and so here we get baselines on everyone. And so We're a specialty clinic, so we see people from out of town, but so we see you whenever you come and see the neurologist. So I do recommend, especially with the atypical Parkinsonism, when you get diagnosed, or you start right away, is just getting a baseline evaluation, kind of see, even if it's just a check-in or education on what type of exercise will be best for you to help prevent and maintain function for as long as you can. Medicare does cover maintenance therapy for Parkinson's and Parkinsonisms. So we very often will pick up people for monthly sessions, once or twice a month, depending on need. And so that we're just reinforcing and keeping on top of things so that if we do start to notice a problem, then we can be proactive about it instead of waiting until, oh, now you're falling all over the place. Then now let's start to work on your balance. More so like, oh, we're noticing these changes. Let's look at, is a device what you need, or do we need particular exercise? And as well as, working on range of motion. You don't want to come in when all of a sudden you've lost all this postural control, and then now you need to be able to work on sitting up so that you can eat. So we find that kind of, and then you have a relationship with the people that you're with, and you trust them, and it can be really helpful to be more of a maintenance basis. Now, if you're not having a lot of issues right away, maybe it's just a check-in every 3 or 6 months. And then even if you are on a maintenance therapy, if you're starting to have some more issues, then they can increase the frequency to address any acute concerns and then go back down more to a maintenance. And I do believe I left my email at the end of my presentation. So if anyone is with a clinic that they're like, oh, I haven't heard of maintenance therapy, I'd be glad to kind of communicate what that might look like. It's a very minor change in how you document, but no additional documentation. But it is a service covered by Medicare.
Interesting that you're ending on that, because we got a question in the chat that says, did someone say Medicare does cover PT? And this would apply for OT for maintenance. And if this is denied, what options do I have?
If it's denied, basically that's kind of up to the clinic to whether or not they're going to appeal. I would lean, if you're having troubles with insurance coverage, going with hospital-based systems, you're probably going to have better luck. Because they just generally, they're kind of used to absorbing some costs, if that makes sense. So sometimes you're more likely, and then also they're more used to a varied client set, where if it's more of an orthopedic clinic, then they're used to seeing people for 6 weeks, they make progress, and then you're out. And so they may not understand the nuance of how to document progression or even maintenance with a progressive disease. Did that answer the question?
Yes. And, in my experience too, I'll say it kind of varies. The availability for maintenance therapy can vary clinic to clinic sometimes, because there's I know some clinics here in North Carolina that are able to do this, and people can just do it almost indefinitely. And they know how, the therapists know how to write the notes so that it is continually covered, and they have the availability to do so. And I know some clinics where they say, like, we wish we could do that, we see the value in it, but then we wouldn't be able to get in all of the new referrals that we get, and we just, it's not set up that way, that they don't have the infrastructure. So that's also something to consider, is like, is this where you want to go? Are they able to provide that? And then
I guess I should specify too, this is mostly outpatient. There are some home health agencies that are playing with this and seeing like our home care services, they are doing it for specific Medicare patients as well. So it can be a little bit harder to ask for maintenance in a home health setting, but outpatient, it should be covered. Yes, according to availability of the clinic.
All right, a question for Dr. Brummet that came through the chat. Could you please explain the screening process for eligibility for clinical trials? How strict are criteria?
That is something that really varies a lot trial to trial. I mean, examples of the types of things I see for trials in this space include time since diagnosis, whether you've had certain types of surgery or been on certain types of treatment, where you are, on the symptomatic scale. A common thing is, how many steps you can take on your own, or different types of metrics that are, going after current physical capabilities, but it's really variable. It depends a lot on the study, depends a lot on what they're testing and how the trial is set up. So I'm sorry that is a very non-answer to this question, but it's something that truly varies so much. And I think that's just following up on a point I made earlier. I think this is where your clinician and the people running the clinical trial will really be able to help if there's any ambiguity about the eligibility guidelines. They'll be able to give really clear guidance for that particular trial on whether it's a fit for you.
Yeah. And I've also seen eligibility around like subtype, like clinical subtype of a diagnosis. Yes. So sometimes with PSP trials, they're only looking for people with PSP Richardson syndrome. Yeah. Or with MSA, they're only looking for people with MSA Parkinsonian subtype. Sometimes the presence of a care partner to take you to the research appointments or to fill out certain research paperwork, it can be part of it too. So
yeah, absolutely. And it's really frustrating, and it's really difficult to navigate at times. From the trial's perspective, these guidelines often end up very strict because they have to set clear expectations about what they're testing and what benchmarks outcomes they're looking for. And so a lot of the times the guidelines are both going after, they might be related to the specific drug or element they're testing. It might only be applicable to certain subtypes or people with certain, symptoms and things like that. And it also just helps them clearly lay out the trial design and understand the findings. And so unfortunately, a lot of the times they do set really strict eligibility criteria or very specific eligibility criteria, not necessarily strict, but it's challenging. It really is, and it varies a lot. So I think the best situations, like I said, just to keep in touch and discuss.
Question that Rachel, I think that you could speak to, I'm happy to as well, or even Dr. Brummet, if you want to weigh in on this. This person shared in the chat, impulse control issues with PSP is making things challenging. And what advice do we have around that? I mean, it's a big question, but maybe, from your perspective, how do you address that when it comes up in your clinic, like how it interacts with activities of daily living and safety issues in the home?
Yeah, I think a lot of times is kind of looking at things proactively. So if even just thinking about leaving the person with PSP alone is thinking about all the things that, like, just leaving the room, even like what might be the things that they might get up for and without someone there is, did they go to the bathroom? Do they have something to drink? Like, is the remote control within reach? Just making sure that the environment's set up and needs are met. Yeah, it's a challenging one. Sometimes even, there are sometimes sleeping alone at night, getting up alone at night. There are alarms for the beds that can be helpful. You can even use that in a chair or a recliner. Just can be notifications. Sometimes baby monitors are actually good. They have both video and audio ones so that you can kind of hear if things are going on, and that can be used during the day or at night. It could even be used almost as like a one-way walkie-talkie type way, so that someone could communicate need if they're alone. This is once again where also working with the therapist can be helpful, because sometimes it's about utilizing the same verbal instruction every time for certain techniques or movements or how to get up or how to get dressed and things. And so routine and consistency helps to decrease the need for kind of change in sudden movement. So it's not going to be perfect. And a lot of times there's a certain point where like continuous supervision is recommended. But there are some techniques and tools that can be used in the meantime.
Yeah, absolutely. And I was thinking with that too, like it depends on how it's showing up. And so working with all the different disciplines around how it's showing up in their realm to give tools, specific could be helpful. So I've seen some success, and it's also not perfect, but even just leaving a walker in front of somebody, directly in front of them when they're sitting down, it's like a visual reminder, don't get up without using your walker. Or sometimes this can show up with eating, like with PSP, people like just shoveling food in their mouth, which can be a swallowing risk. And so working with a speech language pathologist around strategies to accommodate for that. So it's a great place you could bring it up to a neurologist, but definitely turning to allied health clinicians on how to adapt to that. Okay. I have a question that I hope you all don't mind that I'd love to speak to, that we actually received for Tuesday, but I didn't have a chance because we got so many questions for Dr. McFarland. I didn't have a chance to speak to this, and I did end up emailing this person, personally to answer this, but it's such a good question, and I'd love to just share it here because I hope that it's relatable for other people watching, which was, this person asked if we had any tips for mentally preparing for the constant changes and adapting to them over the course of the disease. And what I shared with this person and my response to them, offline about that, is to intentionally allow space for the roller coaster of feelings that can come up over the course of this disease journey. So noticing them as they arise, notice how they might intersect with one another, sometimes even seemingly opposing feelings like, joy and grief at the same time. Noticing how they evolve over time. Like you could even think back to the emotions that you were experiencing when first diagnosed to months later to years later. What got easier, what got harder, and naming them too. So naming, anxiety or anger or ambiguous loss or anticipatory grief or gratitude or whatever it is as it comes up, because naming them is a really good way to help normalize them and also understand them, and reminding yourself that, all of them are normal. There's nothing that you're going to feel throughout this that you shouldn't be feeling. So allowing yourself not to judge yourself for those different emotions that can come up too. I also recommend thinking back to how you've adapted since you were first diagnosed, whether that was weeks or months or years ago. Somehow you figured out how to deal with them and you've learned from that. And you can apply a lot of those same skills to yourself now and to going forward. And likewise, thinking, how have I adapted and dealt with other unexpected challenges that have come up over the course of my life, completely unrelated to this disease? And what can I take from that worked or didn't really work that I could apply here? I also shared with this person to learn what you can about the diagnosis, and you all watching this are doing that. Just, your proactivity, I think that's a word, is like you being here is showing me how proactive you are in approaching this and learning about the disease. I always, a lot of people will ask their neurologist or other team members, what can I expect? It's a really hard question to answer. And a lot of times the answer that we get is not satisfactory. So thinking about different ways of getting at the information you're looking for. So maybe asking your neurologist for guidance on how to plan ahead as best as possible, given what they know about the typical or most common course of this disease. And, for, Rachel, thinking about you here, I also shared this with this person, having an occupational therapist come and do an in-home safety evaluation and make recommendations for modifying the home space can really help with, accommodating somebody's independence and safety in the home now and helping them prepare for some things that might come up down the road. And then a couple more thoughts and then I'll stop, is that completing healthcare advanced directives can be a really good tool to guide conversations around how to prepare for the future. We have a few different resources around that at CurePSP, and you can ask your neurologist or a social worker or a palliative care specialist to help you complete that tool. And then working with a mental health therapist to process this experience, make sense of it, add to your toolbox of coping strategies for it too. And then my last thought was tapping into support groups or peer supporters. So connecting with other people who have walked or who are walking similar paths as yours is just incredibly valuable, and asking them this exact question of like, how did you or are you mentally preparing for this and adapting to the changes? So, Rachel or Dr. Brummet, from your work with this community over the last year, do you have anything you'd want to add to that?
And I think a lot of that is a lot of what I would say. I will reinforce that, like, getting in with a therapy team, it can be really helpful for this. In some ways, you can kind of also trying to find those moments in your day that you're not constantly thinking about your diagnosis. So doing things that give you joy and pleasure and let you just kind of feel like the human being that you are and not the diagnosis that you have is real important and can be a challenge, but is helpful. But with therapies, you can kind of get some of that monitoring so that you can maybe forget about it a little bit, and then just when you come in and handle it, and then you deal with things as you do, because you've probably had symptoms that you never thought you would be able to handle if someone told you about it 20 years ago, and so yet you're living your life with it now. And so that same thing will happen even as the disease progresses, that you will humans are adaptable, and it's not no one wants to be in this situation, but we will adapt and you will adapt. And you have tools around you and people around you that hopefully will help you with that.
Yeah, love it. Thank you. Okay, well, we are at time. Any last minute thoughts or words of wisdom, Rachel or Dr. Brummet, that you want to share before we close out here? Don't all jump in at once. Come on.
No, I'll just say thank you for letting me join you today. I really enjoyed being in person in Orlando, and it was a pleasure to join in the virtual space today. And we look forward to providing research updates, hopefully, as they come along in the future.
Yeah, thank you as well. Meeting the whole CurePSP team and everything, it's been really wonderful. And definitely, I think that as someone with the atypical Parkinson's or a carer for that, those people, it seems like CurePSP has your side and is a really great resource. So yeah, thank you.
Appreciate that. We're trying, and we have such a good team here, and we're backed by and get to collaborate with so many people across the medical community as well, not unlike yourself. So, well, both of you, it was really great to have this conversation. I sure learned a lot. Thank you for contributing all of your expert insights, and so have a good rest of your day.